here live at the STS, and I'm very delighted to be accompanied by the wonderful, the one and only Emily Parkins.
Thank you.
Thank you for visiting, and thank you for being here with us. I feel bad because we've worked you like a dog today, haven't we?
Oh.
So tell us.
Hashtag almost famous.
Yeah, yeah, but you have done a whole load of interviews. What time did you start at the STS today?
Oh, well, we started at 6:30 a.m. with the extraordinary women in cardiothoracic surgery breakfast.
And you had an extraordinary woman, didn't you?
Yes,
Tell us all about that.
Yes, we did. So there were 3 award recipients, excellent, amazing, outstanding rock star women. So let's see, Dr. Schwabe, Dr. Carpenter, and one of our own, Dr. Shanda Blackman.
Yeah, absolutely. Did anything stand out for you in particular? Who's your favourite?
Oh,
you got a soft spot?
I
All
we'll have
three,
to make
of
3
course.
different versions of this video and then play them separately. So but Dr. Blackman has been part of CTSNet, right, for some time,
absolutely.
and so of course we feel a little partial to her.
Yeah, well, it's her birthday, so how about
right, exactly.
Best birthday wishes to Shanda today on receiving an amazing award this morning for all her lifelong work in the field of diversity, inclusion, and promoting women in surgery. And you've actually done a few other really amazing interviews, because there's been some really impactful sessions, and really the one I was just horrified just now, 10 minutes ago, an amazing survey showing that women in their first job are only paid 80% of what men are. That's from Britain. That's outrageous. You know, that doesn't happen around the world.
Right.
Yeah.
So
I mean, are you shocked, or you knew that?
Well, I think we knew that the disparities existed, but Dr. Sherry Erkman sort of headed the task force with the first STS endorsed compensation survey and got really compelling and pretty enlightening data about that exact value. So what we were talking about was how nice it is to have some leverage and have some talking points when you do negotiate for your compensation.
Yeah, and again, the one nice thing that you did bring out was that actually the STS is doing something about it, that they're not putting under the carpet. They're actually saying, here is a problem, we're doing it as openly as we can, and we're actually going to make efforts to try and right that. And the other thing that came out I thought was really interesting is it's that first job, that first attending job, that's where it kind of falls over a bit, doesn't it?
Right, and we had Dr. Meghana Heldner, who is 5 years out from her training at Mayo, and she was expressing how, when you make that first negotiation, you have this sort of imposter syndrome of you don't really know if you can perform X, but you're negotiating for X. And so it's really, it's important to have that kind of STS endorsed data to help.
Yeah, and I guess everybody going for their first job is nervous, but actually, it's now fact that women, stand back, whereas us bolshy blokes go in 2 feet, and it's making a difference. So yeah, I was really impressed with that. So thank you so much for that interview. It was really great.
You did some great interviews as well, right?
Yeah, well, we've actually been here. We've done a whole load of really interesting interviews, all the way from esophageal surgery to many other areas. Lots of diversity inclusion, which is really great. And I'm actually tomorrow be interviewing Roger Flores. I'm really looking forward to Bernie Park about robotics. So there's huge amounts of other things going on. So yeah, it's going to be a busy 2 more days really. So do look out for our videos. We're going to be posting them out every week. Interviews from here at the STS. So yeah, it really is a good little session here in lovely San Antonio, where it's 5 degrees centigrade. Or 40 degrees, but it's super nice. So we've got 3 papers out there as well this week posted up for you to have a look at, and I think they're really very interesting. The first one was by Joe Chikwi. Joe Chikwi, known to us all, another fabulous paragon of women in surgery, but actually so much more. The other interesting thing is this paper, which is about the differences between surgical mitral valve replacement and edge-to-edge transcatheter repair. She's got it published in the JTCS, and as ATS editor, I quite like the fact that she's passing it around a little bit. But she's done this really interesting study whereby she took from the Medicare Medicaid records 53,000 mitral valve interventions from 2012 to 2019. She got rid of the really urgent ones, the things that couldn't have had transcatheter valves, and that leaves 27,000 in this analysis. And out out of them, 7,700 patients have had transcatheter edge-to-edge repair. And that's quite a shock to me, because in the UK, it is nowhere near this prevalent, like not even close. And the most shocking result of this paper is that surgical mitral valve repair and replacement is down 30%, while obviously edge-to-edge catheter is going up. But then so they looked at disparities, because obviously they're a little bit older and frailer, but actually when they do a baseline comparison, they're comparing in pairs, they still got a difference in survival, and it was big. 65% transcatheter versus 85% surgery, and that is after matching. So we've got a problem here, and it's big, and it's TAVR all over again. And you're an adult cardiac surgeon, and are you seeing this in your practice?
Well, we do see it. I mean, we see the enthusiasm, some untempered enthusiasm for expanding TEER in multiple practice settings. And so I think data like this that's so robust will put a little bit of perhaps the brakes on that kind of enthusiasm.
Yeah, and it's kind of shocking, because I don't think it's quite like TAVR, is it? I mean, TAVR provides a good valve with no regurgitation, but that's not the case, is it, in edge-to-edge repair?
Well, not yet anyway. And, some might argue that these data were from, what did we say?
2012 to 2019.
Yeah, and so I think some cardiologists might make the argument that that was early in their experience, and if you look at more contemporary data, that those results for TEER will improve, and we hope that's the case. But it's always important to remember that the surgical option is a good one.
Yeah, and I guess if Jo Chickwee were here, she'd be saying, well, we need to look at trials, we need to set these up. And I know Pat McCarthy and many other people are looking at providing the right trial. But I guess it's important to get the right trial and to learn from previous studies as well, learn from the TAVI experience, get maybe an independent study, not industry sponsored, and try and get at this in an equitable way.
With multidisciplinary input, as always, with the heart team. So,
absolutely. Right. Yeah, that's great. So that was a really great article. It's on CTSNet right now. It's on the front page, so take a little look at that. And then Emily, I know you've had a huge experience in pediatric surgery, and we've got a really interesting story that for me was quite interesting. I'd actually never heard of this before, and basically it's called the first partial heart transplant. So it's a really interesting story. We posted a lay account because I just thought it was really heartfelt and really nice. It's about a little child called Owen Moore. He was actually at Duke University, and Joseph Turek is the lead author, because actually this has been simultaneously published in JAMA. And this patient had their aortopulmonary arteries fused. They're a neonate, and as Joe Turek says, this is a very difficult situation in pediatrics, because if you replace this with a valve, they're too small. They're going to have repeat surgery. And in his article, he actually says this is going to be like a 50% mortality over the coming years. Is that something you've seen in your practice? This is a difficult problem.
Well, it's the Achilles heel of congenital surgery, really, is tissue not growing with the child, right, over the years. And so there have been so many ways to try to tackle that problem. And this is a really unique one that seems to have so much promise. I think the other thing that Dr. Turk brought up is that this opens the option for the domino heart transplant, which means if you're getting an organ for a patient whose myocardium is failing, but their valves are functional, those valves go to a recipient, and the patient who's donated them gets the actual heart transplant, and you've helped two patients with one donation. And how amazing is that? So
yeah,
really
no, that's such a great point, actually. Yeah, and that's really interesting. So they took a heart that was not eligible for full heart transplant, and they took the aorta and pulmonary arteries with their valves and transplanted them into Owen when he was only 18 days old, and so that went really well. But the really key thing is that this was over a year ago, and so they followed this up for over a year, and indeed the valves are growing with the kid. So that is great. So congratulations to them. I'm sure we'll see, this more and more again. And yeah, what a great concept, reducing that mortality from a horrible 50%. So the third article that we have chosen for you is another thing that's quite topical, and it's from Volkmar Volk and colleagues from Germany, and they've looked at the cardiosurgery atrial fibrillation case AF registry data, and they are telling you about surgical ablation of long-standing persistent AF, one-year outcomes from their enormous registry. And it's actually really topical because I got the chance to meet Ralph Damiano. It was great to see him. He was one of my interviews. He's a great guy, a real advocate of AF surgery, took over from Jim Cox, of course, who is still going well, I hear. He's actually still operating.
Is that right?
Yes,
No.
he's still operating, Jim Cox. So
fantastic.
yeah, apparently you can't peel him off the patients. He loves it so much. But this particular study was looking specifically in the CaseAF registry data. This is a really big database, and between 2017 and 2020, over 1,000 patients in this, and they were looking at the really hard ones, the long-standing persistent. So this isn't just all comers AF, and they looked at how they did having AF surgery, and actually overall, mostly these were concomitant. Mostly this is people having mitrals, as Ralph Damiano said. The heart's open in front of you, just do it. He was trying to tell us, but the results of this really were very impressive. It basically said that 50% of people having AF surgery after long-standing persistent had no AF, and 93% were asymptomatic due to AF. So it's actually showing phenomenally good outcomes of AF surgery concomitantly, mostly with your cardiac surgery. And this goes really well because there's an STS guideline coming out, and we talked about that a little bit. And literally, we're at grade 1 evidence for everybody going into your ORs with AF. You really should be doing something about the atrial fibrillation. As Ralph Damiano said, he's demonstrated studies of 20% improved long-term mortality in these patients. And so I guess I've done a bit of cardiac surgery, and you're kind of, another 20 minutes, long bypass time. Where do I do the lesion lines? It's a bit of a chew on, isn't it? But I guess it's the right thing to do.
Can't argue with 20% improved mortality, right?
Yeah, well, that's the thing, and I guess it's who advocates for it, isn't it? Really, because I guess the cardiologists aren't really asking us to do it very much. The patients don't know that we can do it, and it adds 20 minutes to the operation. So I think you have to just understand the STS guidelines, the levels of evidence we're at, really, and that study after study and randomized trial after randomized trial is saying do the AF study. And actually, this paper also said cryoablation was superior to other forms of ablation at doing that pulmonary vein isolation as well. So great paper. Volkmar Falk, he's here at the STS as well. He's been whizzing around, and take a look at that on the website when you get a moment. So onto our videos, and we've got 3 beauties for you. The first one continues Vincent Gaudiani's wonderful series on how to take out a TAVR. Have you had to do this much? I think I asked you a bit earlier. You haven't had to do too many, have you?
Only a handful, but I'm grateful that the numbers are low.
Yeah, and did they come out okay?
Define okay.
The patient's still alive.
I wish
Hi,
I
Martin.
had these videos first.
Yeah. So yeah, we're having a live webinar, by the way. Say hello,
Very
Martin.
good.
Why not?
Hello.
Yeah, this is Martin Cerny, friend of the show on CTSNet, and nice to see you.
My pleasure.
And do you know Emily, by the way?
Hi, Emily
Nice
Martin.
to meet you.
She's one of our top people who's been doing a load of interviews. But actually, Martin Cerny, lots of people know Martin, but he's actually runs a guideline committee at EACTS. And actually, tell us 2 minutes. Tell us about your aortic guideline that's coming out.
Yeah. Okay, very good. Spontaneous occasion. So I would say what are the main points? One main point is the aorta now is the 24th organ of the human body.
Oh.
Yeah. So this was the first and most important recommendation that the entire writing committee agreed because of the complex function and the functional unity the aorta provides. It should be seen as an organ. So first important thing. Second important thing, proximal thoracic aortic pathology. A lot of details with regard to root and ascending acute and chronic pathology. Most important points. Indications remain between 50 and 55 millimeter according to cuspidity, root or ascending phenotype, but at the end there is a leftward shift. So the new, let's say, cutoff is 52 at the end. Yeah, so what was 55 previously is now 52. Aortic length is one of the major components, or is now the first time a component of the decision-making process. So because we know from the Yale data that aortic length beyond 11 centimeters is a risk factor for aortic dissection. So length is now a substantial component of the decision-making process. I still have 10 seconds.
Oh, yeah, absolutely. Yeah, for the highlights. Going up
Okay.
for the highlights.
Very good. And I would say the last point is the consensus on hypothermia, because there was a potpourri how to talk about hypothermia, where to measure, and we now have the consensus. Everything above 28 is mild, everything between 20 and 28 is moderate, with high moderate 24 to 28, low moderate between 20 and 24, and below is deep.
Wow. When are
That's
these coming out?
Next week online, both in the European Journal and in the Annals.
Wow, amazing. Well, you heard it here first. Wasn't that great? Well,
Good.
what a great meeting. And so nice to see you. And
Same here.
yeah, and we'll profile this on CTSNet.
Excellent. Yeah.
Great. Thanks
Okay.
a lot, Martin.
Thanks for
Well,
stopping
yeah. Oh, and
24th organ of the human body.
I
Who
love
knew?
that. I
Yeah,
love
it's
that.
great.
Yeah, that's so cool. Yeah. We're nothing if not spontaneous, are we, on CTSNet?
That's right.
So yeah, that's so cool. Yeah, and brand new. So yeah, that was quite a lot different. Yeah, changing the actual
Yeah,
aortic diameters.
Absolutely.
That's actually a bit more of an earthquake than I thought. I was just
Right.
thinking he was going to just do a few tweaks, but that's
And
pretty
utilizing
huge.
length as the
Yeah, I
as
know.
part of the
Yeah,
decision process.
that's great. Well, I'm actually going to read it. Yeah, so we'll have to have a look at that. So where were we? We were talking about TAVRs, and luckily Emily has done 2 fantastic TAVR explants with
I wish
perfect.
I had the video first.
Yeah, well, it's great. So the video is all about the mustache, the handlebar mustache technique, where you grab the TAVR between the left coronary and the non-coronary cusp, and then you rotate like you're rotating your mustache, which I love. It's a great analogy. But then you cut between the left and non-coronary cusp, which is great because if you make a bit of a hole in the aorta, that's where you'd enlarge it anyway. And Vince Gaudiani does a lot of enlargements, and so he's not too scared of that. And sometimes he says, if you've got a really stuck TAVR, just cut it out from there onwards. So it's a really good series. He's in, I think, his 3rd video on it, and this particular one is an aortic and mitral replacement with double patch repair and aortic root reconstruction. So this is where he really did get into the root. It really got sticky. It was horrifically nasty. I had to look away at some points, but he's such a master, and he does such a lovely job of narrating these. I do encourage you to go and have a look, especially if you're about to face one of those operations shortly. So well done to him. The second video we've got for you is actually a really fun one from Mark Ruel. And he's done a 1-hour seminar all about OPCAB surgery, off-pump cardiac surgery. And he's got Gianluca Torregrossa and Donna May who also with him. Now, I was an on-pump surgeon, and I think you're an on-pump surgeon too, but he does quite a good job of trying to persuade us the utility of off-pump surgery. And really, he says it's an enabler. He says, because if you're going to go off-pump, then, you can then go to minimally invasive, mid-cabs, T-cabs, all that sort of thing. So I guess that was his top tip. But then he's got 10 top tips to make off-pump surgery better and easier. And actually, they're really logical. They're really great. He does his proximals before his distals. He chooses the worst lesion first. He talks a little bit about some experience of patients crashing when he's doing a diagonal. And he actually found that that's because they are accidentally crushing the LAD by accident. And that is a common cause of crashing on off-pump surgery. These are things we'd have to worry about, isn't it, being on-pump surgeons? But so that was a good tip. And then he actually lowers the blood pressure to 90 doing his top ends. He raises it to about 120 for his diagonals and 150 for his circumflexes. So he raises it up on purpose before twisting the heart so that he doesn't get any blood pressure problems. And I think that was only about 4 tips. He does 10 on the video. So check it out for the other 6 because he does a really nice job. It almost wanted me to go and throw away the bypass machine and have a go after watching it. And he really likes he likes his little starfish as well. He loves that more than his octopus. So and he uses that to quite good effect. And he's got a few little videos about that. So it's a good job, Mark. I really enjoyed that video. And then the final one is again by a friend of CTSNet. Have you ever met Payman Sadari Nia? He's from Maastricht, and he's an absolute genius. He does
Okay.
thoracics, he does cardiac, he does minimally invasive, he leaps tall buildings, and he's also invented this incredible 3D practice simulator for port access mitral. So he 3D prints all the valves, and he's got about 10 in his armamentarium, so anterior leaflet, posterior leaflet, bi-leaflets, barlows, all sorts of things, and he loads them into the simulator, and then you get to do your stitching. But the clever little machine can detect how many millimeters of depth each of your stitches are. It's actually better than practicing in a real person, because it tells you the metrics of every single stitch.
As you're doing it.
Literally in front of you, there's a little screen at the side, and it gives you an assessment of your sutures. You want one, don't you now?
Well, it's like being at Orange Theory, which is one of the gyms we have here, and you're working out, and it shows you your heart rate and when you're in the zones and all of the feedback that you get that makes the practice more rewarding. So how interesting.
Well, the good news about this video is you can try it at home, because this is a mobile simulator. It's called a Telesimulator. So he can actually send one to your house over in America, and he has a station in Maastricht, and he can patch it over because there's a video camera inside it, and you can just use your own iPad. It's cheap and portable, and he can coach you while he's still in Maastricht.
Really?
This is awesome.
Do I order this on Amazon or?
Yeah. Where can we get this now? Payman, we need you on the phone.
Right.
So yeah, but he's actually got this. He's actually presented some data of the first 11 people he did this with, sending it to their homes. He actually invented it, obviously, from COVID, when people couldn't travel to him, and it's an absolute banger. So it's just a 15-minute video. It really takes his training processes to the next level, and we love it. Payman, you're a hero, and yeah, you've already got a sale here already. So
That's great.
yeah,
I'll give you my credit card number after.
Yeah, that's great. And those are our 3 videos. So that was absolutely great. It just leaves me to say one honourable mention. I wanted to give an honourable mention to John Treffalls. Now, John Treffalls, some of you won't know, but he is president of the TSMA. That's the Thoracic Surgery Medical Association, Medical Students Association. And the reason for giving him an honourable mention is he says he always listens to the podcast when he's out running. So, John, keep running. You're only 30 minutes in. You're 21 minutes in, actually. You need to keep going. Don't stop. But I'm very proud of you that you listened all the way to the end, and it was really nice to meet you. And I did in fact do a little interview with him as well, because actually he would really like to pair up medical students who can't access CT surgeons with CT surgeons, so medical students just come and visit. And actually he brought one of his colleagues who was one such example. He was in a university, had no CT surgery program, and he paired them up with a surgeon, and that guy's coming into CT surgery. So actually he wants loads of us to just sign up, and you can go to the TSMA website and just say, sure, I'll take a medical student. Why not? It's the easiest thing in the world, isn't it? And
Absolutely.
you never know, you might meet your future colleague, might you? So
As easy as ordering a Telesimulator.
almost, and cheaper as well.
Right.
And we actually got chatting to him, and actually medical students are amazing video editors. So we've got a whole new project
Just
on.
in general, all of them.
Well,
all of them are
yes,
amazing.
yeah, as all of them are. Well, the really funny thing is that I said, how can we contact you? He said, you can use Twitter, you can use our Facebook account. And I said, do you have a website? It's like, he stared at me like this is some old guy and talking about a website. I don't think young people use websites anymore.
At least
But
you
he
didn't
said-
ask if you had a MySpace or something like that.
Yeah, I would just get so confused, the poor guy. But anyway, he stared at me like I was an ancient old dog. So yeah, but yeah, get a medical student in your life if you want to do some editing. And actually, we talked to him about a very exciting new program that we are going to do, which is unedited videos. We're going to try and get videos from people like yourself who've got amazing videos, but not the time to edit them. And we're going to put them in a big repository and pair them up with residents, medical students to edit them up, because I think it's a great way to learn. They can take your video, they can learn, then they maybe send you a few questions like, what the hell did you do there? And you weren't meant to see that. But actually, isn't that great? We can have our videos
Great idea.
edited. You've got someone to help, and they'll learn off them as well.
Well, they add like flattering filters and things
Uh,
to it.
You'd hope so, wouldn't you?
I would, actually.
Yeah, quite. That's compulsory, that is.
Right,
Yeah. So I think that's been really fun. So yeah, I've had a great first day. You're now in hour 12 of being here, I believe.
I
so-
am, but I'm
and-
going strong. Just
Yeah,
Like you.
and what time are you getting up tomorrow then?
3:30-ish.
Yeah, poor thing. So yeah, thank you so much, Emily. She's done 12-hour shift for us. She's getting up at 3:30 for 5 a.m. flights to get home to be on call, I believe.
Yes, but it's been wonderful.
Yeah, great. Well, thank you so much. You've been absolutely wonderful. And keep an eye out for all Emily's awesome videos and my dodgy chatting as well. So, and thanks to everybody for watching our podcast here at the STS in San Antonio. And catch us next week. Well, I'll be back tucked up in chilly old England, going through the best news and events of the day.